Luis, bienvenido.
Thank you very much, Dr. Ballesteros. Again, it's a pleasure to be here among you. I was tasked to talk about refractory variceal bleeding, and it will overlap a little bit with Dr. Durante's talk. So the term refractory is really loosely defined, and then I think a practical definition of a refractory variceal bleeding is that which is persistent or recurrent within the first 5 days of presentation despite standard pharmacologic and endoscopic, namely band ligation therapy. The Baveno consensus definition is commonly used to define therapeutic failure in the setting of acute variceal bleeding. However, I would note that any of these criteria can be met without actually having recurrent variceal bleeding. So it has to be taken with a grain of salt. Regardless, refractory variceal bleeding accounts for up to 15% of all acute variceal bleeding episodes, and its importance lies in its high mortality rate, as high as 50% in some studies. And importantly, rebleeding is a strong predictor of death. So I would like to highlight for you the therapeutic options we have available for in the acute setting. And these include second-line endoscopic therapies, namely alcohol-based sclerotherapy, glue injection, as well as hemostatic spray, bridging techniques, including balloon tamponade and self-expandable metal stents, and definitive therapies, which include TIPS and less commonly surgical procedures. So let's highlight some of these techniques over the next few slides, starting with sclerotherapy. Can you play the video, please? So this is a patient who presented with an actively bleeding varix that could not be controlled with band ligation because of prior band-induced scarring in the area. So in this type of situation, our second-line therapy would be an alcohol-based sclerosant. So we would consider sclerotherapy as rescue therapy when ligation fails or ligation is infeasible because of torrential bleeding. It is important to note, however, that the volume injected is based on the type of sclerosant that one is using. And there's always the issue of intra versus paravaricial injection. There are less local complications with intravaricial injection, but in the active setting, in the acute setting, it is very difficult to know what is intravaricial or paravaricial injection. So the intent here is obviously to achieve hemostasis. Now, not all sclerosing agents are the same, and I think that's my point here. It depends on what sclerosant you use, and depending on the sclerosant used, the maximum volume per injection site will vary based on the particular sclerosant utilized, as well as the maximum volume per session, okay? And this has to do with the relative tissue potency of the sclerosing agents. So if you're using ethanol, for instance, absolute alcohol, you really would want to inject only about 0.5 ml per injection site and no more than 5 ml per session, because it really damages the tissue because it is so potent. There are a host of adverse events related to alcohol-based sclerotherapy, as enumerated on the left. The picture, the CT scan showed on the right, is a patient who underwent salvage alcohol-based sclerotherapy following band ligation failure. And so bleeding was controlled, but he came back a month later with dyspnea as a result of a large right empyema, which was a result of an esophagopleural fistula secondary to alcohol-based sclerotherapy. Fortunately, he did undergo surgery with drainage of that empyema, decortication, and closure of that fistula, and surprisingly, he did well despite his underlying cirrhosis. So just be aware of the sclerotherapy-based adverse events, and at least be ready for them should they arise. What about glue injection? Okay, so this is a patient who failed actually both band ligation as well as alcohol-based sclerotherapy. and he was not a TIPS candidate, and the only option really available, at least in our hands, was glue injection. So here we are injecting just a small amount of glue, typically no more than 1 ml per injection site. However, there's really limited data on the use of glue injection for esophageal variceal bleeding, and it's limited to case series. My issue with glue is the risk of serious adverse events, including an intense inflammatory reaction, as well as embolization and fistula. So this is immediately after the glue injection with achievement of hemostasis. And when the patient came back 3 months later, this is what you will expect to see. So you might see retained glue cast, as well as expect to see deep scarring, because the glue again can cause deep ulceration, as well as mucosal bridging, which obviously increases the risk of fistula formation in this setting. So in our hands, at least in our practice, we limit glue injection, salvage therapy when everything else fails, including interventional radiologic techniques. Hemostatic spray, it's been touched upon. It just got recently approved in the US. This is a treatment of this is not a varix, this is actually a duodenal ulcer bleed. So the spray is a highly absorptive powder that forms a mechanical plug that adheres to the bleeding site, and it also activates the clotting cascade, promoting hemostasis. So the advantage of this is that it is a non-contact device, and it's very easy to use. However, do note that it is not indicated for variceal bleeding, at least commercially when it is advertised, because of a fear of embolization. The spray is given under CO2 pressure, and the fear here is that some of this powder could infiltrate into the varices and embolize, although this fear is more theoretical than practical. As Dr. Durantes mentioned, this was a randomized controlled trial that just came out the past month, that evaluated the role of hemostatic spray, hemospray, in cirrhotic patients with acute variceal hemorrhage. And this is a new strategy which consists of immediate upper endoscopy with hemostatic spray application within 2 hours of presentation, followed by early elective endoscopy the next day within 12 to 24 hours of admission for definitive therapy. So that was a study group, and they compared that to the early elective endoscopy only group, which is the control group. In terms of the results, for my talk, which is about rescue therapy, refractory bleeding. So rescue therapy, which means that therapy that was required prior to elective endoscopy, this was required in 5 of 43 patients, which is the study group, versus 13 out of 43 patients in the control group. So it was effective at decreasing the need for rescue therapy, 12 versus 30% in this study. However, since my discussion is about refractory bleeding, you should know that in this study group, of those who failed, 4 out of 5 had spurting bleeding and could not be controlled with the hemostatic spray. So the spray itself has really not been studied for refractory torrential variceal bleeding. So how will it fare in the setting of massive torrential bleeding? I don't know. And what is its role as bridge therapy in this type of setting until definitive therapy can be performed? That remains to be seen. So let me now move on to balloon tamponade. There are 3 types of balloon tamponades available. The 2 on the left are utilized for esophageal variceal bleeding. It consists of a Stank-Staken Blakemore tube and then the Minnesota tube, which has an extra suction port in the esophagus. And then the one on the right is a Linton-Nachlas tube, which is reserved for fundal variceal bleeding. The balloons on the left don't work very well for fundal variceal bleeding because of a limited capacity of the balloon when maximally inflated. The balloon on the right, the Linton-Nachlas tube, can be inflated to 600 ml, okay? So it can really give you good tamponade when one is dealing with fundal variceal bleeding. My message with balloon tamponade is have a protocol, have a standardized protocol as to how to use it, and at least have people that are experienced in the setup and in its utilization. So here at Mayo, we certainly have a protocol written up in the ICU so that they can refer to as to how to set up the balloon tamponade. We do use a pulley system, and the I don't have a pointer, but at the end of the pulley is a 500 ml bag of normal saline that is attached to the pulley to provide traction and tamponade. Now, with balloon tamponade, hemostasis can be achieved in up to 90% of cases. However, the balloon needs to be deflated within 24 hours to minimize the risk of tissue necrosis from balloon pressure. And it has to be considered as a bridge therapy to something more definitive and no more than 24 hours. Do expect a 50% rebleed rate following balloon deflation, so one has to be ready for a definitive therapy. And there's an up to 20% mortality rate due to serious adverse events, and this is primarily due to inexperienced personnel placing the balloon. Can you start the video, please? So this is a patient that came in with massive torrential esophageal variceal hemorrhage. As you can see, there's a band that's sitting right there, and despite the band, he's still having overt bleeding. We then proceeded with sclerotherapy. Initially, it looked like we had the bleeding under control, but then after a few minutes of observation, bleeding came back with a vengeance, okay? So failed band ligation, failed sclerotherapy. So because of that, and at some point the bleeding was so torrential that we had a readout of the endoscopic view, so we had to pull out. So because of that, obviously we had to tamponade the bleeding, and we proceeded with placement of a Minnesota tube. This was placed by the ICU team. There was initial control of bleeding for about 10 minutes or so, but then fresh blood started to exit the mouth and the esophagus, the esophageal suction port of the tube. So if you had to guess what happened in this case, anybody? Nobody wants to venture? Can you play the video, please? So we were still in the ICU when the tube was placed, so we said, let's just have a look and see. As soon as we put the endoscope in, we encounter this, okay? So the esophagus is on the left, and there's a large rupture right in the center. What you're seeing on the right is a lung, okay? So major bleeding, huge rupture, okay? Dehiscence of the whole, essentially the whole esophagus down to the GE junction, okay? So this is a terminal event, okay? So what happened here is that the rupture was likely due to balloon misplacement. The patient was not a candidate for salvage surgery, and care was withdrawn after conference with the patient's family, okay? So it can happen, it has happened, and it will happen. So what do we do now? If in case we're asked to place a balloon tamponade, we do it with endoscopic guidance, okay? So this is a massive bleeding, again, from an esophageal varix around the GE junction or so. So what we actually do is that we will bring the balloon tamponade by lassoing it with a snare at the tip of the scope and actually bring it down into the stomach. We then inflate the balloon in the endoscopic view to make sure that the balloon is being inflated in the stomach. Once it is inflated in the stomach, the scope is withdrawn, and then the balloon tamponade is put in place. So if you have an option, especially if something that you don't place commonly, if you have an option of placing it endoscopically, that would be probably one way of minimizing the risk of inadvertent balloon misplacement and esophageal perforation. Let me go back. So the alternative to balloon tamponade, obviously, is the dedicated self-expandable metal stent, which is the XIII stent. This is a 13.5 centimeter long by 25 millimeter wide, fully covered metal stent that was designed specifically for variceal tamponade. And although it can be placed without endoscopic or fluoroscopic guidance, I would suggest that this is placed under endoscopic guidance via wire, over a wire. And the indwelling time of this stent can be up to 14 days. And the beauty of this stent is that it can be removed without any trauma using a dedicated extraction device. Now, we don't have this stent available in the US. I'm not sure about here in Mexico, but it's a fairly simple way of placing this stent over a guide wire. It also has an integrated balloon at the end, which will allow you to pull back on the stent delivery catheter to really have a good tamponade at the junction before stent deployment for precise stent positioning. And this whole setup is fairly easy to use after having played with it ex vivo. The other neat device is being able to remove this without any trauma. And there's a dedicated device shown on the right that allows you to do this by hooking the stent at the top and then essentially pulling it back through this capture catheter device. Okay. So what's the efficacy of this stent? There was a large systematic review that encompassed 155 patients. The technical success was over 95%, which is pretty good. And clinical success defined as absence of bleeding within 24 hours of stent placement was 96%, which is also very good. There were several adverse events, and they were mainly due to stent migration. They counted that as an adverse event. The rebleeding really was relatively low following stent placement. There is a multi-center randomized controlled trial that looked at dedicated SEMS versus balloon tamponade. This study was criticized because of its low enrollment numbers, as you can see here, 13 in the SEMS group versus 15 in the balloon tamponade group. So the only conclusions we can take from this study is that yes, SEMS placement is successful at achieving hemostasis, at least as effective as balloon tamponade, but likely with a lesser risk of serious adverse events, 15% versus 47% in the SEMS group. Although this did not achieve statistical significance, but I think again it was because of a low rate of enrollment. There was no impact on mortality when comparing both techniques. And I know another question you're going to ask me, well, what about putting a conventional esophageal SEMS if you don't have a dedicated LR-DANI stent? Yes, you can do this, and we have do this, but beware. Number one, it is not approved for this purpose. Number two, there can be suboptimal tamponade because those stents that we use for non-variceal indications, the configuration is not meant for variceal tamponade, okay? So the tamponade may not be as effective as a dedicated DANI stent. And third, more importantly, is traumatic removal, okay? So at some point you have to remove that conventional stent. And there are a couple of ways that one can do this to minimize the risk of, tearing the mucosa and causing bleeding. But I can tell you it can be very difficult sometimes to remove these stents without causing much trauma. So expect, at least hope for the best, but be prepared for the worst. So, tamponade and refractory bleeding, according to Bavino consensus statements. With regard to balloon tamponade, given the high incidence of its severe adverse events, it should only be used in refractory esophageal bleeding as a temporary bridge for a maximum of 24 hours, with intensive care monitoring and considering intubation until definitive treatment can be instituted. The second point from the consensus statement is that data suggests that self-expandable covered esophageal metal stents may be as efficacious and a safer option than balloon tamponade in refractory esophageal variceal bleeding. So given the totality of the evidence, if I had the choice and if I had the dedicated SEMS, that would be my first choice over balloon tamponade for bridging therapy. I can't talk about refractory variceal bleeding without mentioning TIPS. Of course, with regards to TIPS, covered stents is the way to go over bare stents because of improved patency and decreased risk of encephalopathy. As rescue therapy, however, although it is effective at achieving hemostasis in over 90% of patients, the overall outcome, however, remains poor, up to 50% mortality in some studies, and usually it's due to the liver failure and complications related to liver failure itself. There's also the risk of liver decompensation, especially in patients with high MELD score or Child-Pugh cirrhosis, as well as the risk of encephalopathy following placement of TIPS. With regards to TIPS and refractory variceal bleeding, the Bavino consensus statements indicate that persistent bleeding despite combined drug and endotherapy is best managed by TIPS. Rebleeding during the first 5 days may be managed by a second attempt at endoscopic therapy, but if rebleeding is severe, one should consider TIPS as the best option. A couple of slides on surgery. You got the shunt operations as well as the non-shunt operations, which is much less commonly used nowadays. With regards to the shunt operations, you have a portocaval shunts, as well as a selective shunts, such as a distal, as well as a proximal sphenorenal shunts. I won't go into detail regarding these surgical techniques, as they are beyond my expertise. Needless to say, they are rarely performed nowadays, and there's an up to 50% mortality rate, primarily due to liver failure and surgical complications. The potential surgical candidate would be the one with a well-preserved liver function, no complications from the actual bleeding episode, and importantly, there's a contraindication to TIPS placement. So this is my last slide regarding the suggested management algorithm, especially in the setting of rebleeding. As mentioned, one could consider second endoscopic therapy. This is rebleeding after failure of drug and band ligation. So I might reconsider band ligation if appropriate, otherwise consider sclerotherapy, and in the rare circumstance, a glue injection. If bleeding is controlled with second endotherapy, then one proceeds with secondary prophylaxis. If bleeding is not controlled, then it's either rescue TIPS and rarely surgery in select cases. If one is dealing with severe torrential bleeding with hemodynamic instability, second endoscopic therapy usually is not very successful in this setting, then one should consider either SAMS or balloon tamponade as bridge therapy. I question the role of hemospray in this setting. Time will tell. And obviously with a bridge therapy, one has to proceed with definitive therapy, namely rescue TIPS and occasionally surgery. That's it. Thank you very much for your attention.